Thanks a lot, KP. Thanks a lot, Dr. Sonu Goel, and thank you again for the opportunity to speak today. So I'll be speaking to you a little bit about what we've learned about surface ablation. I think, and the reason why I want to speak to you about this is because I think you heard Dr. Mahipal Sachdev speak a while earlier, where he said that he promised that flaps are going to disappear in the near future. And I believe that one of the reasons flaps are going to disappear in the near future is because of PRK or surface ablation and not just smile. So surface ablation, if you remember our training about 15 years ago, was used only in some patients where they were not suitable for LASIK, either because of a poor surface or if you had scars or professional requirements. But now it seems as if surface ablation is becoming a procedure of choice for several patients as well as surgeons. And to take you back in time, this is one of the patients that I like to show from 2002, almost 20 years ago, who underwent microkeratome LASIK for a very low refractive error, minus 3.5 and minus 0.75 cylinder, good residual stromal bed of 300 microns. This patient came 5 years later with some inferior steepening in the left eye, young doctor. And then later on in 2010, 8 years after surgery, she had definite ectasia in the lower part of the cornea. And the patient is somebody who keeps haunting me from the point of view of having ectasia that I have to deal with now, 20 years after she had surgery with somebody else. Post-LASIK ectasia is mainly underreported because most of the people actually call them as keratoconus rather than ectasia. And incidence is about 1 in 2,500 cases, so relatively common. And if you look at the risk factors for ectasia, one of the risk factors for ectasia is actually doing surgery in patients who are young. And in India, you know that our patient population is relatively young. And if you're operating somebody between 18 and 21, they automatically fall into risk category 3 for post-LASIK ectasia. And there are several reports available in literature which talk about how patients who underwent LASIK in one eye developed ectasia, but the contralateral eye in which they underwent PRK for whatever reason did not develop ectasia, which actually also shows that even in the same patient, it looks like LASIK obviously has a higher risk of resulting in ectasia than PRK. I briefly went through the literature available on ectasia. And if you look at the reports of ectasia post-LASIK, all these red bars, there are more than 200 publications about post-LASIK ectasia. There only are about 4 after PRK, and you see the green bars after SMILE, they actually are increasing since 2016. So it seems that PRK potentially has the least risk of causing post-LASIK ectasia or post-refractive surgery ectasia, if I might say that. We really do not know what is the cause for ectasia. Could be biomechanics, could be eye rubbing, genetics, could be pregnancy related. Nobody really knows. But what is universal is the fact that it seems that surface ablation has a lesser risk of causing ectasia. And this is the reason why at LVP, over the last about 10 years or so, we've shifted from doing 30% of PRK to currently, if you look at the green bar in 2019, close to 70% of PRK or surface ablation for our patients. LASIK is about 25%, SMILE is about 4%. And when we looked at our data from the last 6 years, 10,000 eyes, we saw that the majority of patients actually were in between the refractive group of -3 to -6. This is only myopes. About 25% were between 6 and 9 diopters, and about 5% were actually more than 9 diopters. Average age was about 25 years, and we found that we had 4 distinct groups of distribution for PRK in myopia. And when we looked at the results, we found that the results in all 3 categories, either 0 to 3, 3 to 6, or 6 to 9, were comparable with not much difference between them. Accuracy was comparable as well, with 95 to 99% of patients being within plus minus 0.5 at the end of 1 year. And stability was comparable between the 3 groups as well. So we also started looking at doing PRK and very high myopia. And this is an example of a patient with -1175 and -2 who underwent PRK. And she actually is 20/20 plano over time. And we have close to 300 eyes where we've done the same kind of PRK in high myopes. And when we looked at the follow-up of 130 eyes that we had follow-up for 1 year of more than 9 diopters, again, we found that 93% of them are plus minus 1 diopter after surgery. And this is exactly what you would expect after any other refractive correction. Probably not as accurate as those between 1 and 3, but I think within the acceptable range when you do PRK for high myopia as well. We found that haze was really not a concern, only about less than 1% who had severe haze, and only one patient in all these groups who really required intervention for haze after a long time. So to summarize, in the last 5 years, we did close to 14,000 PRKs in eyes. And of these, only about 0.15% of patients required resurgery. That is 21 repeat PRKs. And when we looked at the reasons for repeat PRK, 24% undercorrection, 24 overcorrection, 24 residual. So about 75% of them were because of refractive errors, and only about 28%, that is 6 eyes out of close to 14,000 eyes, needed surgery for haze after PRK, which dispels the myth that PRK actually causes significant haze. And we also found that the time to recovery of visual acuity after PRK in almost all subsets was about the same, and they stayed quite stable after the recovered vision at 1 month. So to conclude, surface ablation, we believe, is important now because ECTASIA will happen after LASIK as well as SMILE. It seems, and I don't think we still understand why it happens. I believe it's like endophthalmitis. All of us are going to get ECTASIA at some point of time. After PRK, you have no striae, no folds, no ingrowth, nothing to worry about from the point of view of complications that occur in LASIK. From the data that you saw, it's very predictable and very stable. And at the end of maybe a week or so, it seems much more comfortable for both the patient and the doctor because you don't have to worry about long-term complications anymore. Thank you very much. I'd like to